السلام عليكم. Shall we start? السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Good morning everybody, and we would like to welcome you all to SIMEC 2022 under the umbrella of King Khalid University and the Saudi Medical Education. I am Abdullah Asiri. I'm a professor of cardiology, King Khalid University. I was a former dean of College of Medicine, King Khalid University. And I'm honored to share this session with my co-chairman, Dr. Muna Sheikh, who's an associate professor in Al-Imam Abdurrahman bin Faisal University, and she's a known Saudi figure in medical education. The first session today is going to talk about assessment and the feedback. And to tackle this topic, we are having 3 international speakers, and they are figures in medical education. It's going to be through the website, so through the online sessions. And I would like to remind all speakers to stick to the time allocated, and we will leave the discussion to the end of the presentations at the panel discussion. I will ask my colleague, Dr. Muna, to present the first presenter.
Assalamu alaikum wa rahmatullah. Welcome all to the first session of the Saudi International Medical Education Conference 2022. This conference is unique because it coincides with the 20th anniversary of the Saudi Society of Medical Education. And it's also unique because it's the first medical education conference after the COVID-19 pandemic. So we hope that in the next sessions you'll be hearing about the crisis management during the pandemic, the stable management, and the new normal. So please stay tuned and enjoy the sessions. Our first speaker is a pronounced eminent speaker, Lambart Schuwirth. He has obtained his PhD degree from Maastricht University, and he has been a leader in student assessment. He has been pioneering the work and innovating in student assessment. He has been the chair of the task force on assessment since 2000, and he has been an advisor of assessment to all medical colleges in many medical colleges in the Netherlands and UK, and he's been chairing the International Consensus Group on Educational Research, the results of which were published in the Journal of Medical Teacher. Since 2007, Lambert has been a full professor for innovative assessment at Maastricht University. Currently, he is holding a professor position for medical education at Flinders University in Adelaide, Australia. Please listen to Lambert and please put questions, because we're going to have a question and answer session after the speakers finish. Thank you.
Thank you very much, kind hosts, and good morning to all of you. I want to thank you for allowing me to speak at your conference. And I think it's one of the wonders of technology that I'm speaking to you and presenting my slides without having to do any travel. The only problem communication technology hasn't been able to solve yet are time zone differences. So it's morning where you are and it's evening where I am. But I'm very pleased that I'll be able to speak to you about a topic that has always been the center of my interest, namely assessment. And today I want to focus on programmatic assessment in combination with what's known as assessment for learning. So I've given the presentation the somewhat misleading subtitle, Tips for Application. And now you may think that this is a presentation that will be about a sort of 12 tips for the application of programmatic assessment, or a straightforward roadmap to application of programmatic assessment or assessment for learning, but that's not the case. And I feel that I need to explain to you why that is. Because an important consideration is that education and assessment are actually quite complex phenomena. And they are always the result of interaction between numerous factors, and most notably, of course, the interactions between learners and their teachers. And it's not to say that complex phenomena are always difficult, but they are certainly not straightforward or entirely predictable. And that has consequences for how we see the nature of evidence in medical education, because evidence in medical education is different to, for example, evidence in clinical research. In clinical research, we assume that the outcomes are valid regardless of whether they were found or where they were found and where they are being applied. So if a therapeutic intervention, a drug, works in London, it's safe to assume that it will also work in Tokyo, New York, Vancouver, Adelaide, and of course in Riyadh. But in medical education, there's an interplay between different sorts of evidence. Examples are findings about limitations, or there is generic evidence that's always true, wherever you find it. So an example is findings about the limitations of the short-term memory and its relationship with information in the long-term memory and how that applies to learning. But there is also context-specific evidence, things that are true, but dependent on national or local culture or context, typically values and beliefs, but also the way education is financed, the expectations of society, and many more. These are important to consider because what may work in one society or given that society's culture may not at all work in an entirely different society. So that means that the effectiveness of educational approaches needs to be understood so it can be adapted to the local circumstances. And this is not entirely different to clinical practice because despite evidence-based guidelines, a good understanding of the patient's pathophysiology will allow you as a doctor to slightly deviate from the guidelines and personalize your approach to each patient. And then finally, there is the impact of your organizational context, your staff, the level of educational literacy of your staff, the strategic plan of your organization, the leadership, etc. And all these three sources of evidence have to be taken into account when trying to apply an assessment approach such as programmatic assessment. So you could almost say that trying to apply programmatic assessment at your own organization in exactly the same way it has been applied somewhere else is more likely to fail than to be successful. So the logical question then is, to which problem is programmatic assessment assessment for learning a solution? Because the last thing I would like to see is that people embrace a solution simply because it looks good or because it's popular or because it's a hype. Because what you need to do is a clear analysis of the existing problems and whether your solution is a good solution to the problem. So here are 6 of what I think central problems with the way we currently assess our students. And the first one is that we assume that the traits or the constructs, the things that we try to assess with our assessment are stable and generic. So if we assume that somebody, we measure an aspect of somebody's competence with a test, we assume that we can very clearly distinguish between those who are highly competent and those who are not. So if this is one of these tests with 4 items, 1, 2, 3, 4, and 5 students, A to E, this test tells what this test tells us is that student A is highly competent and student E is highly incompetent. But what you see here is that student A performs well across all 4 items and student E performs poorly across all 4 items. And that's why student A has achieved a score of 4 and student E only achieves a score of 0.8. So now, if we now assume that if we had a so-called parallel test, a test of equal difficulty on the same topic, but with a slightly different question, like this one, we would assume that we actually would find again student A to be the top scoring student and student E to be the bottom performer, and that the rank ordering from A to E would be the same on both. That's basically the fundamental to test-retest correlation, Cronbach's alpha, and what have you. So in an ideal situation, when we're looking from a criterion validity or a criterion perspective, In an ideal situation, we could even expect that student A would again obtain a score of 4 and student A would again obtain a score of 0.8. But unfortunately, practice is quite different. It's a different picture. There's a lot of interaction. There's a lot of scatter in how students perform. And in this matrix, student A may be the top performer when it comes to item 1, but he's absolutely not the top performer when it comes to item 3. He's almost a bottom performer. Whereas for student C, the picture is quite different. They are the top performer with respect to item 3, but a bottom performer on item 2. And on the parallel test, you would find, again, a lot of interaction and a lot of scatter, but it's an entirely different scatter. So let's assume that item 1 is on cardiology and item 3 is on respirology. And then assume that there are 2 students, Jenny and Tom. Jenny does well on cardiology, but not so well on pulmonology. And Tom does well on pulmonology, but not so well on cardiology. From an educational point of view, it is more interesting to understand why Jenny didn't do so well on respirology and why Tom didn't do so well on cardiology. Actually saying that from an educational point of view, that differential interaction is much more important than just saying you can compensate performance on one domain with competence on another domain. But in our standard psychometric approaches, the classical test theory, but even generalizability theory, the interaction between cardiology and respirology and Jenny and Tom is generally part of the error component. We say it's error variance, and it's not the signal or the true score variance of our measurement. The other assumption is that they are generic or independent. We typically assume that the format of the assessment determines what the assessment actually measures. When you ask somebody about their assessment, the typical reply is in the format of, we use multiple choice. And of course, considerable amounts of research have been performed, especially in the 1980s and 1990s, where they compare different assessment formats. And the most popular types of studies were, of course, comparing open-ended and multiple choice questions. And these studies were typically done either in a multi-trait, multi-method, or in crossover designs as depicted here. And in crossover designs, one part of the assessment was administered in multiple choice format to one group of students, and the second part was an open-ended format. And for the other group of students, the first part was open-ended and the second part was multiple choice. And that way you could make an analysis of the impact of question format and question content. And invariably, the results showed that competence did not generalize very well across content. So that's assumed by the diagonal arrows, because where the format was the same, they were both multiple choice, but different content. And the green vertical arrows show that where the content was the same, but the format was different, correlations were extremely high. That's counterintuitive, but it's a very robust finding. And the most plausible conclusion is that the traits are neither stable nor generic. And it's a basic assumption about underlying our testing. So in order for traits to be stable and generic, we also have to treat individual items as meaningless because we're looking at a trait. We're not looking at the item. We're not looking at cardiology versus pulmonology. We're looking at overall traits. So items are only there to contribute to the total test score, but they're not seen as meaningful in themselves. So let's say this is multiple choice item 1, and here is multiple choice item 2. And let's assume that one student answers item 1 correctly, but item 2 incorrectly, and another student items 1 incorrectly, but item 2 correctly. So they would both obtain a score of 0.5, but on different knowledge. And you could argue that in the multiple choice test, oh, this is acceptable. After all, the amount of information from each item is fairly limited. But how about in an OSCE? How about a student that performs very poorly on a resuscitation station but very well on a communication station. Is it logical to assume that on average they both deserve a score of 50%? Or if there is another student who performs very well on the resuscitation station, but very poorly on a communication station, and thus also receives a score of 50%, is it fair that both students simply obtain the same score without any further educational consequences? Well, in my opinion, it's not. It's not defensible because it doesn't make sense. It doesn't make sense to say you can compensate for poor resuscitation skills with good communication, but it's a consequence of our traditional model of assessment. As a consequence of treating individual items as meaningless and using them only to contribute to total score, that total score seems to be what determines validity, particularly the assessment construct's validity. But when we determine validity, we look only at the behavior of total scores and whether that behavior is in accordance to what we expect. For example, do experts outperform non-experts on the test? Or in other words, whether their total scores are higher than those of non-experts. But if we consider total scores, and these total scores are the results of a combination of individual item scores or blueprint category scores, we actually have to be quite careful to ensure that we're combining components that make sense together. Like I said, competence doesn't generalize well across contents. And if everything is translated to a number and simply arithmetically or mathematically combined, there's always the risk that we add apples and oranges as depicted in this joke. So it is mathematically easy to simply add up population, the number of feet above sea level, and the date of establishment, and arrive at the number of 4663. But it's obvious that these are individual components which are meaningful in themselves and should not be combined. So logically then, when we apply statistics, they have to be based on elimination of information. If you try to express competence on a single scale and treat all the individual items as meaningless, information has to be reduced and thrown away. So here's an example. These are the responses of a student to 3 questions. And at this point, you know exactly which correct and incorrect answers were given. And I can determine which misconceptions the student had or even which patterns of misconceptions there were. All that information is here. But now I start scoring and now have lost the quality of the misconceptions that there might be. The only thing I now know is which items were answered correctly and which were not. So in the next step, I tally up the scores and calculate the total score. Now I've lost the information with regards to which items were answered correctly and which were not. I now only know how many items were answered correctly and how many weren't. And then finally, I sort of compare the score with a cut-off score to determine whether the student has passed or failed. And now all the information has been lost and it's dichotomized into or reduced to fit into one bit of information, a yes or no, a pass or fail. And you could argue that that's not always the case because we sometimes give grades, but grades are still a very limited number of categories compared to that rich information we started with. But that's something that we need to do in the testing paradigm. So if we are forced to reduce information, it is only logical that we try to find the instrument that does this data reduction, this information reduction in the best possible way. And logically, there is a tendency, or there has been a tendency in the literature to find the single best instrument for each trade. And obviously, the best instrument has never been found. And it's logical because it's a matter of horses for courses. No clinical researcher would ever dream of conducting research demonstrating that antibiotics are better than NSAIDs, because the answer simply depends on whether you're trying to treat pneumonia or sterile bursitis, for example. And then finally, there is the implicit assumption that behaviorist drivers, punishment and rewards, are the best drivers to ensure that students actually study and study well. And at the risk of stating the obvious and telling you something that you already know, behaviorism is a very, very straightforward view on influencing human behavior. There's a stimulus, which is observed by the students, which leads to a response in the student. In our case, that's the student's learning or study behavior, which leads to a consequence, typically passing or failing the exam. And the possible ways in which these drivers work are positive and negative reinforcement and positive and negative punishment. And again, at the risk of stating the obvious, positive reinforcement means the student does something I like, I do something the student likes. Negative reinforcement means the student does something I like, I take away something that the student doesn't like. Positive punishment means the student does something I don't like, so I do something that the student doesn't like, the slap on the wrist. And negative punishment means the student does something that I don't like, so I take away something that the student really likes. The typical example is if you don't finish your plate, your food, you don't get dessert. And a well-known fact in behaviorism is that when the reinforcement or punishment are discontinued, the behavior has a tendency to go away, to fade out. Okay, these can be seen as problems, but the question remains, why are these problems? After all, this has been common practice in assessment over the world, all over the world, for decades in a row. So here are 5 issues that I would like to present to you. The first is that competence is actually multifaceted. And it's much more multifaceted than we assumed in the rather simple knowledge, skills, problem-solving ability, and attitudes model, the simple traits model. We know that competence is situational and context dependent. And it changes over time. And it has multiple aspects which all contribute and all interact with each other. And this is reflected in the competency models of almost all major organizations in the world. Medical expert, medical knowledge, or good clinical care are basically what is meant with knowledge, skills, and problem solving. And logically, they are the first to be mentioned in each of these competency frameworks. But there are many more. And they're also seen as integral, as an integral part of competence. And it quickly became clear that we were really able to measure them with a traditional testing approach, and that they required human judgment and subjectivity. So the next problem I already alluded to, but I gave examples only of multiple choice questions versus open-ended questions. But it's actually all across the board. Whatever comparisons you make, if the content is the same, the format is almost completely unimportant. Even in a comparison between the performance on a real OSCE and a written test on skills shows high correlations. And that's counterintuitive because we are used to think in terms of formats and not in terms of content. But the ramifications are immense. If we really want to produce information with our assessment program that is meaningful and useful and that can be acted upon, and whether it's to be used in a learning and assessment of learning context, or to make decisions about whether a student is ready to progress to a next phase or not, or whether we use it in an assessment for learning context to optimize student learning, the information must be meaningful. And for that, combining information that relates to the same content is far better, far more defensible than just combining information that relates to the same format. As a little illustration, you would never tell a patient that their glucose level is far too high, but fortunately their sodium level is far too low, and therefore their average lab results are okay. Because the glucose and the sodium have a meaning in themselves and need to be combined with other information. And modern doctors, the next thing is that modern doctors are not the same as past doctors. What was a good doctor 50 years ago is no longer a good doctor. And what is currently a good doctor will not be a good doctor in 50 years. That changed. The most important development that has happened and is still taking place is the shift from seeing medicine purely as a technical, cure-oriented discipline to being also a humanistic and a more care-oriented discipline. And of course, making the right diagnosis and decide on the correct therapeutic management is still important, but it's not the sole bread and butter of being a doctor. That's why the competency frameworks include so many of the domain-independent capabilities, such as communication, professionalism, collaboration, etc. But there are more. There are actually more changes taking place, and they are taking place in society. And they are having and going to have a huge impact on medicine, how we practice medicine, and on medical education. And of course, there are things like changing demographics, changing technology, changing therapeutics, funding. They all have an impact, but I don't want to focus on those. But I want to focus on these disruptions. And you may think that this is about technology, but it's not about technology. It's about changing fundamental changes in society. It's our connectedness. Through internet technology, we're so much more connected with each other, for better or for worse, and connected with a world of information. And that is leading to fundamental changes in how we do things. And from the many that are happening, I want to highlight 6. And the first relates to what you could call point of care access to information. Current students and graduates, and also patients, have a world of information at their fingertips. And this is fundamentally different from, for example, when I graduated from medical school. I was expected to have the vast majority of that necessary knowledge in my head, and all I could bring were 2 little books and not all the bookshelves with reference books. And that information exists in the internet because of what you could call cognitive surplus. Apparently, humans have a sort of inbuilt desire to share knowledge, to teach and to share information. Where before the internet, if you had a problem, you would have to ask a friendly neighbor or a friend who knew how to fix it, or hire a professional to help you. Nowadays, everybody's first port of call is Google, and which will typically redirect you to a website where somebody has made an instruction or an instruction video even showing you exactly how to solve the problem. Another consequence of this increased connectedness is the way we manage trust. Traditionally, trust is institutionalized. When a patient visits a doctor, they had to simply trust that doctor. It was in the institution of a doctor. Or when I wanted to go to have dinner in a fancy restaurant, I would look up that restaurant and the quality in the Michelin Guide. And the Michelin Guide is written by a couple of experts who had visited that restaurant once or twice and then wrote their review and gave their rating. Nowadays, if I want to go to a restaurant, I actually look up Google reviews, and I typically look at the top reviews and the bottom reviews and see how the restaurant has dealt with the reviews. So instead of placing my trust in the institution of Michelin Guide, I'm now placing my trust in the whole internet community. That has also changed the way we perceive knowledge, because knowledge was always seen as something that the expert had, and the expert was right, and the non-expert did not have the knowledge, and therefore the non-expert was wrong. But currently, we see knowledge as something that has multiple facets and is collaboratively constructed. So the compelling analogy is with the traditional encyclopedia, which was written by a group of experts and held more or less immutable, unchangeable truth, to Wikipedia, which is constantly, it's written by a large community and it's constantly renewed and advanced. And these have led to what's called a degrees of expertise asymmetry. When I graduated from medicine, the predominant view was that I, as doctor, knew everything, the patient knew nothing, and I had to tell the patient what was wrong with them and what was going to happen. And that has changed, because in many cases, the patient has done their homework. And regardless of whether this has led to correct knowledge or incorrect knowledge, it dramatically changes the dynamic in the consulting room. Given the idea of knowledge co-construction, it often leads to a situation where both the doctor and the patient add complementary expertise. There's a funny saying, funny joke in the internet in which a doctor tells the patient, "Don't you think that your hour of Googling is a substitute for my 6 years of studying?" Whereupon the patient replies by saying, "Don't you think that your hour lecture on my illness is a substitute of my experience of living with it for 20 years?" So finally, it's not unreasonable to expect that artificial intelligence and machine learning will have a dramatic impact on the medical profession in the way it's going to support and augment and sometimes even substitute traditional doctor roles, typically making a diagnosis and deciding on the optimal treatment. And that is again aligned with the view that non-discipline specific abilities, collaboration, communication, empathy, etc., feature ever more prominently in the competency frameworks. So a purely behaviorist framework is not enough to drive student learning. As I already said, if your drivers are purely behaviorist, it is likely pardon, that the desired behavior fades out when the reinforcement or the punishment are discontinued. And that was not a problem in a time when I graduated from medical school. So the dominant notion was that medical school would have prepared me with all the skills, knowledge, attitudes, and problem-solving ability to last me for the rest of my career. Of course, I was expected to update my knowledge, for example, if a new treatment modality would become available. But now it is actually likely that students will have to continue to study and reinvent themselves in their roles as doctor or in their professional development, professional identity development, because of those rapid changes, those disruptive changes that I was talking about, which are constantly taking place. So instead of a steady state after graduation, a continuation of development, of learning and development. So not just lifelong learning, but lifelong adapting will have to take place. And from a behaviorist point of view, that is simply not enough, because it's then important to realize that the span of control ends with graduation and then it stops, whereas our responsibility to society starts on day one after graduation. So that leads us to the principles of programmatic assessment and assessment for learning. And the first one is that any aggregation, synthesis, or triangulation of information has to be meaningful. It has to be a narrative, a story. Only that way we'll be able to make better informed decisions about whether a student is ready to progress or not, but we are also better able to provide that student with feedback. And students will therefore better be able to optimize their learning. So even large assessment programs with many instruments, you could say, well, they are multi-instrument and therefore they're a program of assessment, but it doesn't work if every instrument leads to a score, a grade, or even just a pass-fail decision. And then you add up all these scores or pass-fail decisions, because that information is not meaningful. And even if you add everything up, it will still not be meaningful. And that's what I wanted to illustrate with that example of Franz Kuyama, where you add apples and oranges to come to the total score of 4663. No, it's actually about meaningful triangulations. And meaningful triangulations means that instead of adding scores mathematically, you have to take bits out of each assessment modality that can be combined in a sort of narrative that tells you how something is doing, their progress, their achievement in a competency domain. For example, parts of a mini CX or an essay of a 360 degree, and then some feedback tells you something about the achievement in the role of communicator or health advocate or other domains. And of course, for that, you need multiple sources of information. Sorry. You need multiple qualities. And you might think, is that possible? Is it possible to combine information from such various sources and meaningfully triangulate? Well, is that doable? Can we do that? Well, it's something that we do as clinicians all the time. A patient consults you with complaints of fatigue, thirst, frequent urination. On inspection, you see poorly healing wounds. When the lab results come back and you palpate weak or absent peripheral arterial pulsations, and then the lab result comes back and the glucose is 35 millimoles per liter. And then when you conclude that the patient has diabetes mellitus, you've just synthesized and triangulated verbal, visual, tactile, and numerical information. The thing that allows you to combine that information into a meaningful conclusion is that you have expertise to do that. So expertise is key. In order to do that in a meaningful way, collection has to take place in a longitudinal fashion. So rather than having a one-off or only a few points in time during which you assess, where each assessment moment is also a decision moment, you have a program in which all the information that could contribute to that meaningful analysis of a student's achievement is collected continually. And obviously that means, like I said, that you have to separate the assessment moment of the decision moment. And every assessment is actually simply a data point that contributes to the richness of information and which you collect in a dossier or a portfolio. That allows you, that separation of decision moment and assessment moment allows you to be proportional in your decision making. High stakes decisions require rich information. Low stakes decisions require little information. Of course, you need that to achieve some better student agency, because when information is rich and meaningful, it does allow for better and better informed decision making. And the student gets that information as well, so they can take control and be responsible for their own achievement, their own study, but even in the end, for their own learning and assessment. And that's the most difficult and courageous part of programmatic assessment and assessment for learning. And it's the one that requires most organizational courage, because there is a long tradition of assuming that students are inherently unmotivated and lazy, and they need the cracking of the whip of assessment to drive their learning behavior. And there is a strongly held belief that when you give students control over their own assessment, they will automatically revert to all kinds of strategic, cunning behavior.
Professor
So
Lambert,
even in an environment
5 minutes.
Pardon?
5 minutes you have.
Yeah, thank you. I'm almost done. So even in an environment where student learning is supposed to be self-regulated and self-directed, we still treat assessment as something that has to be done to the students rather than with the student. And despite all those fear of allowing students control over their own assessment, at least in part, we automatically assume that once they graduate, they're able to do it. How could they if we never allow that? So allowing students to take responsibility is a very important point. Then finally, that means that we have to look at quality beyond the traditional psychometrics approaches. There are components in the assessment program that are more or less traditional, and they can benefit from psychometric approaches. There is the element of saturation. Sometimes you say, I've done observations and I've seen enough, I've reached saturation. Like in clinical medicine, I've done enough diagnostics to to make a diagnosis. But you can also build in your, you can build in expertise, staff development, and you can build it in as part of your organization. Now, finally, I want to focus on, on how to combine this, because they can work in synergy. And again, a clinical analogy works. When I order a lab test, I'm not interested in a lab analyst's opinion. The credibility, I want a number, and the credibility of that number is derived from statistics, population data, measurement validity and reliability. But if I order a pathology report, I am interested in the pathologist's opinion, and I want to read the narrative, I want to read the story. And credibility now comes from the pathologist's expertise, the clarity, coherence, and plausibility of what they write, and how it relates to my question. If the pathologist gives me a number and the lab analyst gives me a story, they're both useless. So again, it's horses for courses. Now, I'm going to finish off by a simple model of what this means for the practice of programmatic assessment, because however you implement it, these are, there's an element of continual collection of data, formal results, informal results, feedback, what have you. A moment, at several moments during the year, when the student analyzes that information, triangulates it, sits down with a mentor or another staff member to analyze that together, and then identify strengths and weaknesses, make a plan for improvement, and execute that plan for improvement. And it's very important that the student takes agency and is accountable and responsible for this. Because a student who does not seriously engage with this, who finds loopholes, who tries to avoid, that's the student who fails in the programmatic assessment for learning. And of course, a student who, despite the good intentions, doesn't make the improvements that they need to make. That brings me to ending up. It's similar to what you do in clinical practice. You collect data, history, physical examination, lab tests, which you review as a doctor or with a patient, which you analyze, you come up with a plan for improvement, and that's basically it. Final slide. So the tips are not a roadmap. The tips are what you need in your organization to make it happen. You need knowledge brokers, people who can combine that stable evidence with the contextualized evidence with local organization and are able to translate that. Simply copying what somebody else does doesn't work. The leadership has to be on board. If your leadership doesn't see the value of changing to programmatic assessment and assessment for learning, it's going to be an uphill battle for the knowledge brokers. You need courage. Innovation is scary and dramatic. The bigger the change, the scarier the change. So you need courage in your organization, but you can't do it alone. So you need to focus on getting buy-in from all your teachers and stakeholders, which you hopefully will help you to create a culture in which this is possible. And only then, if you got these things ready, is it worth making an investment in the change. Thank you very much for listening.
Thank you very much, Professor Lambert, for this elegant presentations and